All right, so now we're going to pivot yet again and hear from MyHIN's resident advanced care directive expert, Reverend and Dr. James Kraft, or as we like to call him at MyHIN, Jim, formerly the system lead for advanced care planning for a large healthcare system in Southeast Michigan. He is now director of the Consumer Choice and Collaborative Care for MyHIN, and he is also a certified Respecting Choices individual as well. He, as a part of the Respecting Choices First, Next, and Advanced Steps trainer, has trained over 1,000 individuals as advanced care planning facilitators. So we're going to be hearing from Jim next. I did just want to let everyone know that we're about 15 minutes behind, but we did work in a break as a little bit of a buffer. So we're just going to continue to go through the content. So with that, I will pass it over to Jim.
Thanks, Shreya. And I want to thank the doctor for his great presentation. I especially appreciated the fact that he's proven that the technology enhances the process, and with the goal of being shared decision making and putting that patient and that individual's front and center in the care, and not allowing the technology to depersonalize it and just take it away. So I especially appreciated your presentation there, Doctor. It's a pleasure to be here today. I've recently come to MyHIN after spending 20 years at the bedside with both hospice and in the hospital. And in my time here today, I'd like to give you a frontline view of the eConsent, known as the Advanced Care Document, or what we've historically called the Advanced Directive. Next slide, please. I want to thank Dr. Wang for touching on some of the issues that we have at bedside care. I think I have found a new best friend, and I'm going to address the current slide, what the current state is in most of our healthcare systems today, and the relationships that many of our physicians have with advanced care planning. I'll use a real world example of a large healthcare system in Southeast Michigan and what the true picture looks like as far as advanced directives are concerned. And then I will use a sample demographic study to show that ACP is not a one-size-fits-all proposition. Next slide, please. So little has changed since the creation and the promotion of the advanced directives following the enactment of the Patient Self-Determination Act in 1990. After 30 years, the national average of those who've intentionally thought through their future medical preferences and documented them in a legal advanced care document is still only between 30 and 40%. So that means that for every patient in our healthcare systems, a full 6 to 7 out of 10 of them will have had little to no discussion regarding the future medical treatment preferences. To compound this situation, research tells us that in their most critical time, between 40 and 70% of all of our patients at end of life will be unable to communicate or lack decisional capacity. Medical decisions will most likely fall to family members who are ill prepared to make life and death decisions, because as the research also shows, up to half will lack capacity themselves or not have proper understanding of their loved one's diagnosis, prognosis, or the efficacy of the treatment being offered. So this creates a perfect storm for insufficient communication, fear, or emotion-driven decision-making, creates opportunity for family conflict, and certainly promotes moral distress on the part of the family and on the staff itself. Next slide, please. Unfortunately, even when those 30% do take the time to think through their medical preferences and document them, there's a good chance, as high as 76%, that their care team will not bother or have the processes in place to identify if that ACD is in place and even act on it. So too often, even when the directive is identified, the directive is disregarded and not followed by family or providers alike. This lack of knowledge or plain disregard for patients' preferences often leads to conflict between medical providers and families. Often these situations get escalated to the hospital ethics teams, And now, instead of being viewed as family, as trusted partners in care, providers are considered adversaries. Typically, what results is not a good patient-family experience. Next slide. I know that our focus today is on eConsents, the electronic side of care. However, I remind myself that behind every consent, every document, every diagnosis, there is a person with hopes and dreams, fears, and real life issues. And behind them are loved ones traveling the same roller coaster of emotions that their loved one is experiencing. Every document is not just a consent to share information, but an attempt on the part of the individual to tell us more about themselves. They're telling us by what they consent to, what is important to them, and we owe it to them to listen. As important as advanced care documents are, more important are the people they represent. We will have served people well if we've not only created and stored a document for their end of life, but we will have done great work if we've equipped them and their advocates to make medical decisions throughout their medical journey. This way, they're prepared and empowered regardless of their medical condition. Next slide, please. So these are the top 5 chronic or progressive illnesses that people in Michigan died of in 2019. In most cases, death was not imminent. Instead, individuals journeyed with their illness throughout many stages. It is throughout these varying stages that we have the opportunity to intervene and help them to assess where they're at medically and where they're likely to go. That is ACP at its best. Often we're not creating whole new documents. Instead, we're giving them and their providers the opportunity to do really good shared decision-making. Next slide. My physician survey indicates that there's a high level of understanding when it comes to ACP and ACDs. The problem emerges in practice. Physicians' practices do not appear congruent with the values they say they place on ACP. And few, less than half, regularly look for the patient's advance directive and incorporate them into their shared decision-making process. Few healthcare systems have built and standardized processes whereby these documents are identified and brought into the care team discussion. And unfortunately, even when there is an interest in the patient's advanced care document, a significant percentage of providers cannot easily access them in the EMR. More than once, I have personally been at the bedside of someone who is being resuscitated, only to later discover they had a directive and chart that indicated they didn't want such heroic measures. Next. I find this audit interesting. Hospital A has a higher percentage of at-risk and underserved patients, yet the percentage of individuals with an advanced care document is the same as Hospital C, which is located in a highly educated, highly affluent community. I personally believe that the hesitancy in creating these documents is not necessarily a reflection on lack of opportunity, but rather because this work, advanced care planning, has historically been positioned as an end-of-life discussion, when in fact the true focus of ACP should be on helping people live their best life possible for as long as possible. Next. You'll see that 70% of the 3,419 patients hospitalized with COVID died. That is 581 souls. Few had advanced directives in their medical chart. I will say that this slide brings me the most grief, because for 18 months I lived and worked watching my colleagues agonize as they care for patients with COVID who did not have an advanced directive to guide them, and many were not able to interact with their patients' advocates in real time. And it still marks me. Next. ACP is not a one-size-fits-all exercise. It's not a one-and-done effort. We are unique individuals with different hopes and fears that change over the course of our illness. We are heavily influenced by our faith and culture, family, social and economic environments. We cannot generalize this discussion and expect people to simply fill out a document and not allow them to express to us the very things that make them who they are. As an example, I present the religious and spiritual community. The research indicates that, as a general rule of thumb, the more religious or spiritual one perceives themselves to be, the least likely they are to have discussed any future healthcare needs with either their provider or their family. They are the least likely to create a directive for future healthcare, and they are the least satisfied with their loved one's end-of-life experience. Ironically, they are also the most optimistic that everything will just work out, even in the absence of any preparation. Next. People of faith are 6 times more likely to want aggressive treatment, even if non-beneficial. And they're 3 times more likely to receive aggressive treatment from their providers, even if non-beneficial. However, once their illness is put in the context of their faith, they are 3 times more likely to enter into hospice. This is just one example where understanding our patients better helps us to better align our care that not only reflects who our patients are, but gives us the opportunity to provide best practice, patient-centered medical treatment. Next slide. So you see we have some challenges, but we also have some great opportunities. We at Mayan and Making Choices Michigan are poised to significantly impact healthcare's ability to go from a reactionary institution to a proactive force that brings our technology, insights, and networks together to advance patient-centered care. In every study or report offered by the Institute of Medicine, communication, or lack thereof, is cited as being the central issue affecting healthcare. eConsent and the other great products at Mayan and Making Choices Michigan provides each of us a vehicle to improve and enhance communication that will no doubt reap untold benefits to providers, payers, and patients alike. Thank you for your time.
Great. Are there any questions for Jim before we move on to the breakout sessions? I think that we are good for now. Thank you so much for the presentation. That was very insightful, and I'm very excited to see how we end up integrating advanced care directives and eConsent together in the future.
Thanks, Shreya.
All right.